And thank you all for staying to the end of the session. I'll try to be as brief as possible. So I'm just going to talk about a little bit from one of my objectives for my PhD, and it's looking at predictors of persistent hepatitis B viremia. So as most of you know, the current WHO treatment and diagnosis guidelines, better? So yeah, so with the current guidelines, the focus is basically on simplifying diagnosis and treatment algorithms. And currently, treatment is now recommended not only for individuals with advanced disease, but also for individuals who have fibrosis, HBV DNA levels of at least 2,000 IU per ml, those with co-infections and stuff like family history of hepatocellular carcinoma. So yeah, Tenofovir usually reduces HBV viral load with around 80% of individuals suppressing the virus within a year of treatment. But then in some individuals, this doesn't happen. So depends on how you define persistent viremia, but in our case, we've defined it as sustained hepatitis B or detectable HBV DNA despite treatment. So there are several reasons why this can happen, and one is that nucleoside or nucleotide analogs do not necessarily target the CCC DNA reservoir. And then we also have the host immunity dysfunction, which is either exhausted T cells or impaired innate immunity, which also contributes to persistent viremia. And then there are occasions where drug levels are just not sufficient or inadequate, more or less. So even though there are instances where we have optimal adherence, then this ends up pointing to other factors such as drug resistance and other host determinants. So in real-world studies, there have been reported cases of individuals who are not suppressing the virus, and in roughly 6 to 40% of individuals who have been on long-term treatment in Ghana, South Africa, Ethiopia, and Zambia have not suppressed the virus. So then, as I mentioned, as treatment eligibility criteria is expanding, we also need to understand why these individuals are having persistent viremia. So we recruited individuals into a cross-sectional study, and these were individuals with or without HIV co-infection, not to mention adults, to be specific. And this was done in clinics in Cape Town and Bloemfontein. And so what we did, we classified individuals into two, whether they were virologically suppressed or they were non-virologically suppressed. And this was based on the definition on they've been on treatment for at least 1 year, and they had HBV viral loads of at least, greater than or equal to 20 international units per mil. So we also retrospectively measured plasma tenofovir levels, and this was done at the University of Cape Town Clinical Pharmacokinetics Lab, and this was done using validated mass spectrometry methods. So then analysis was simply done for comparison between groups using non-parametric tests, among other logistic regression methods. So in general, actually, as at 2025 February, we had recruited 395 individuals in total. And out of these individuals, the median age was 43. And the proportion of male and females were almost similar. And at the time of testing, 75% of the individuals were HBe antigen negative, and 48% were living with HIV co-infection. So among the individuals that were on treatment, the median duration of treatment was 31 months. And out of these individuals who were on treatment, like I said, out of individuals who had been on treatment for at least 1 year, we found that 43.6% of these individuals did not achieve HBV suppression. So from now onwards, I'll be using the words NVS and VS to represent individuals who were non-virologically suppressed versus those that were virologically suppressed. So for association of age with HBV suppression, we noticed that most of the individuals who were non-virologically suppressed were younger. And if we look at alanine transaminase levels as well, individuals who were non-virologically suppressed had a small but borderline higher ALT levels. And for individuals who had HIV co-infection, the non-virologically suppressed group had higher HIV RNA levels. And if you look at the effect size coefficient, it shows that that was quite a sizable number. So like I said, we'd measured plasma tenofovir levels in these individuals, but there were no significant differences in the median tenofovir levels between the two groups. And as not surprising that the proportion of individuals who are non-virologically suppressed, there are a high proportion of individuals with HBe antigen positivity in the NVS group. So in the univariate analysis, we just sort of wanted to confirm that the HBV DNA parameters were a distinct they distinctively classified the individuals into NVS groups. But something that also stood out from the analysis was still that HBe antigen levels and HIV RNA viral load were significant predictors of persistent viremia, and these were now candidates for multivariate analysis. So this simple forest plot just tries to highlight the same thing, that HBe antigen status and HIV viral load were key determinants of persistent viremia. But when you compare univariable and multivariable analysis, we notice that age, well, once it is or adjusted for, then we lose that significance, and that's why we just end up with these two factors remaining as the determinants for HBV non-suppression. So I just also wanted to add that we decided to look at, even though we look at multivariable regression analysis, we thought about training our data, using our data to train a machine learning model. So I can't talk about all of them, but I just thought this was an interesting one to mention. We just used a simple decision tree. And what it did is just show us that if you look at, for example, if an individual was HBe antigen positive, or if the group was HBe antigen positive, there was 79% of these individuals that were non-virologically suppressed. But then, if you look at HBe antigen negative, but with HIV viral load cutoff of greater than or equal to 11, then there was 64%. There was 64% of the individuals who would be non-virologically suppressed. And on the other side of the arm, if there was less than 11 HIV RNA copies per mil, then only 21% of the individuals would be non-virologically suppressed. So, in summary, in this real-world study, we saw that 43% of those who were on tenofovir-based therapy for at least 1 year did not achieve HBV suppression, and HBe antigen positivity and HIV viremia were key predictors of HBV non-suppression or persistent viremia. And ad hoc plasma tenofovir levels in this cohort did not necessarily give us a good adherence pattern, but at least we had HIV RNA levels as an indirect marker for adherence in individuals with HIV co-infection. So we also noticed the role of machine learning in predicting HBV non-suppression, with the caveat that obviously more data equals more power of predictivity, of prediction. So just to mention that our next steps are basically to investigate a role of drug resistance, as my colleague Dorcas mentioned. So we'll be using the same analysis, the same protocol to sort of sequence through, to sequence and generate whole genome sequences. And yep, that's pretty much it. Thank you so much for staying to the end of the presentation. I'd like to thank my supervisor and everyone else who was supportive, and mostly our collaborators. I shouldn't go without mentioning that. Thank you.